Good evening, everyone. Thank you for joining us for the fourth Arrhythmia webinar of the month of September, which is the last session of this series. Thanks for being with us throughout this month. I believe we covered the most relevant topics of arrhythmia that one should be familiar with in order to practice arrhythmia management. Today we chose to make it even more interactive, discuss with you cases that we believe are teaching cases that we can make some good points out of them, hopefully. Please feel free to ask any question. We are here to answer all those questions. I know sometimes we as electrophysiologists go a bit deep in the mechanisms and in the things that interest us, and we can bore you sometimes with specifics, but we'll try to make it as practical as possible. Today we are three speakers. Dr. Marwan Refaat will be joining us in a bit. Looks like the traffic is a bit heavy this evening. The first speaker is Dr. Njeim from Hôtel de France. He will be presenting a case that I know is very interesting, and hopefully you guys will be interested in the thought process when you approach such a case. Mario?
Thank you, Bernard, and good evening, and thank you guys for following this series of webinar. So far we have tried to keep it really simple and just stick to the guidelines and show you what the guidelines say about like bread and butter electrophysiology. Today I will try to continue in the same way and try not to make it too complicated, but at the same time it's interesting to see some cases that can be challenging sometimes and can make us go a little bit beyond what the guidelines can tell us and make us think. So that's why the case I'll be presenting to you guys today is the following. How do I advance? Okay, so it's a case of a Widish complex tachycardia, so somewhere between narrow and wide. And the history is simple. The patient was 24, and he had no significant past medical history. He didn't have any family history, no family history of sudden cardiac death or cardiomyopathy specifically. He came into the emergency room at Hôtel de France 1 hour after the onset of palpitations. And then he reports that he was actually sitting with his friends, that he had a can of Red Bull, and then a few minutes after this, he started noticing rapid onset palpitations that sustained, did not subside, reason why he came to the emergency room. This guy denied using any illicit drugs. And then on arrival, his blood pressure was 110/70. He looked anxious. His heart rate was 150. And then I'll move to his EKG, which is the following, which I hope you can clearly see on your screen, and try to take a few seconds and look at the detail of this EKG. So Dr. Refaat gave a great lecture about how to distinguish SVT from VT, I believe last week. And this case is interesting, it's challenging, because it can break some of the rules that we usually know. And I guess you already know what the next question will be. So when you're confronted with such an EKG, before we get to how we manage this, just to have an idea in your mind, would you say this is supraventricular tachycardia, or would you say this is ventricular tachycardia?
So this is a great question, Mario. I guess when you first look at this ECG, it doesn't struck you like a wide complex tachycardia. I guess that's why you said it's a widish tachycardia. So the first thing that comes to your mind, this is probably an SVT with an aberrancy. Because it's not as wide as one would think. But then when you start looking deeper, you start realizing that there might be something particular relevant to this case.
Excellent, perfect. So that's a thought process that people would have. It doesn't look like a wide QRS, so it's somewhere in between. But if you look at the algorithm, and then you probably can't see the details of this, but I'm going to remind you which algorithms I'm showing over here. So the one to the right is the Brugada algorithm that Dr. Marwan Refaat elaborated on last week. And the one on the left is from the guidelines from 2003, ACC, HAESC guidelines that can tell us how to distinguish between SVT and VT using a number of criteria. Then if you remember, Marwan had talked about what we call concordance. So if we have all positive or all negative waves in the precordial leads, that would be in favor of a VT, meaning if we have no RS complexes in the precordial leads, that would be in favor of VT. And then if you look at this EKG over here, we actually do have RS complexes, so we cannot say that this is a VT so far.
So can I stop you here about
Sure.
the topic of concordance? Some people confuse this when they say that the majority of the forces are upright, for example, they call this as concordance. We should clarify this as concordance. Right. It's absence of RS, so it doesn't mean if we have positive R in V1, but in V6 we have large R, small s, or this doesn't mean this is positive concordance.
Excellent point.
All positive, or all negative.
Perfect. Okay. So, so this guy has RS complexes that you can see very well from V1 down to V6. All of those are RS complexes. So we're not yet at the diagnosis of VT. Then what we can look at is the interval from the onset of the R wave to the nadir of the S wave. And if this interval is large, that goes in favor of ventricular tachycardia as well. I don't recommend that you guys remember the specific numbers and all of this, but it makes sense. So when we're talking about VT, the initial activation for VT comes from the ventricular myocytes. It does not use the conduction system. And that's why the initial intervals would be, or waves, would be broad, because it's cell-to-cell depolarization rather than using a fast conduction tissue. So if this is not the case, and if it takes too much time to get from the onset of the R to the nadir of the S, and too much time is more than 100 milliseconds, this is also in favor of VT. And if you look at the EKG we have over here, so it's not more than 100 milliseconds. So again, it's not in favor of VT. And then we go to the next step in the Brugada algorithm. Do we have atrioventricular dissociation? And then here, I'm going to just recommend that you do not exceed with your imagination looking for your P waves, because we tend to imagine P waves somewhere, everywhere, I mean. And in this EKG, if you look at the inferior leads, you might have a hint of a positive, of a P wave. If you look at V1, you might have a hint of a P wave as well. But it's hard to tell if those are P waves or those are just fractionation of the QRS. So sometimes if you clearly see atrioventricular dissociation, then obviously it favors, it's actually diagnostic of VT. If you're not sure about it, just do not imagine P waves. So at the end, if we're still going this algorithm, we don't see AV dissociation, we don't have a clear diagnosis yet, then we start looking at morphology criteria. So this patient clearly has a right bundle morphology. So we see the R wave in V1, we see RS in V6, and we have, when we have such a morphology, we can use what we call morphology criteria to distinguish between SVT and VT. And here I can tell you that to summarize what those morphology criteria are and keep it simple, does this right bundle look like a typical right bundle, or is this some type of atypical, weird-looking right bundle branch block? So
totally. This is the quick way of looking at things. Does this right bundle morphology is like any right bundle, or this does this left bundle is like any left bundle that you know? So this is a quick way of saying this is an SVT or a VT.
Perfect. So when it comes to a right bundle pattern, what would count as an atypical right bundle pattern that should gear us towards VT? So if you have a QR aspect, or if we have just positive, meaning R prime in V1, that would be in favor of a VT. And if you look at this patient over here, we have a tiny Q wave in V1, and then we mostly have R waves in V1 as well. So that's a QR, which is not the typical RS R prime that you guys would expect to see when you have a typical right bundle branch block. So it's not typical for SVT with aberrancy. And then something else that's actually relevant in this EKG, if you look at the axis of the QRS, so the axis is looking superior, so in the inferior leads we have all negative, and then in one we are slightly negative as well, meaning this is a right upper axis looking towards the right arm, and that's usually in favor of VT because the activation is coming from down to high. And this kind of reflects itself also in AVR, despite the fact that we have a tiny Q wave in AVR before having the R wave.
So you meant the no man's land.
The no man's land, right. But to be fair, that's not the easiest EKG to distinguish between SVT with aberrancy and VT. And in a few seconds, you kind of will know why. So I guess my gut feeling when I look at this EKG is that this is VT, but I'll let you guys decide if you disagree or if you have other diagnosis in mind.
So, but if you look, I know if you follow the criteria, it's really at the borderline of calling it VT
Sure.
or SVT with aberrancy, right?
Sure.
So, with the first impression for me, if I look at it, I would say this is an SVT with aberrancy, right? Then until I dig deeper, I might start wondering if that's the correct answer or not.
Completely agree. So also to take a step back, there are algorithms that we follow, and the algorithm they make sense. So we don't have to just remember intervals. We have to remember why are those intervals meant to direct us towards VT or SVT with aberrancy. But there's also for us electrophysiologists some type of pattern recognition. So when you look at a specific EKG, this looks like something I know. And then in this case, we'll talk about this in a few slides. This does look like something that we know as electrophysiologists that I'll tell you about in a second. But it's not the most common EKG that you will see in the emergency room with people presenting with wide complex tachycardia. What's really good, you don't really need a diagnosis. What you really need to do is to manage this patient.
Totally.
This patient is not feeling well. He's still complaining of palpitations, so you have to jump to managing this patient. And here we'll stop again and then talk about what exactly would you guys start by doing. So I'm giving you a number of options over here. Would you try vagal maneuvers? Would you try IV adenosine? Would you try a synchronized cardioversion? Would you go to Verapamil? Would you use amiodarone? So all of those options are options that we use with patients with tachycardia. So what do you guys think?
So I guess all of those options are not wrong, right? You could try them.
Correct.
You could start with vagal maneuver. It's not totally wrong to give IV adenosine, right? So but for the sake of diagnosis, maybe you should choose the right answer, right?
Exactly. So, I mean, remember that this patient came in, he is stable hemodynamically, which kind of tells us that we don't have to rush and do the electrical cardioversion. And then we have the luxury of trying maneuvers to try to help us with the diagnosis. But I'll take you to this slide, which I believe we kind of talked about quickly. And this is about wide QRS tachycardia, but it's actually in the SVT guidelines and the recent SVT guidelines from the ESC 2019. So what do those guidelines say? And then again, guidelines are guidelines. They are supposed to help us, but they don't decide what we have to do. We make the decisions. So this is a wide QRS tachycardia. The patient is stable hemodynamically. That's why we don't have to rush to do the electrical cardioversion. We have the option of doing the vagal maneuvers, okay? And then if the vagal maneuvers are ineffective, then we can use IV adenosine. And then we talked about this also 2 weeks ago. We can kill somebody if we use IV adenosine if they have a pre-excited atrial fibrillation, meaning different degrees of QRS widths and aberrancy, which is not the case over here. And then if IV adenosine doesn't help, then they favor using IV procainamide. You don't have to worry about it because we don't have it in Lebanon, or use IV amiodarone after using IV adenosine. And then I'll even show you this table of recommendations. So again, if the patient is unstable, class 1 recommendation to do a cardioversion. Please, 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 that's very important for all of us electrophysiologists. If somebody is stable, take time to get an EKG. It will determine what this patient might take as medications or as procedure for the rest of his life. And it just takes 30 seconds. So when the patient is stable, get the 12-lead EKG. It's very important. When you do vagal maneuver or adenosine, please run a rhythm strip. Let us see how the rhythm changes, or if it doesn't change, when you do your interventions like IV adenosine or Verapamil or even vagal maneuvers. So class 1 recommendation for doing cardioversion if the patient is unstable, 12-lead should be done, vagal maneuver should be done. But look at the end of this table. Verapamil is not recommended in wide QRS complex tachycardia of unknown etiology. It's a class 3. Did Dr. Bernard make an error by saying we can use Verapamil? we'll get to this in a second, but for people who do not recognize patterns, when you have a wide QRS tachycardia and you don't know what's the exact etiology of this wide QRS tachycardia, it is preferable not to give IV Verapamil. Now, why is this the case? Because many of those would be on diseased hearts. And if somebody has a cardiomyopathy and a low EF and you give him a negative inotrope, specifically Verapamil, you can actually make them decompensate and then go into worsening heart failure. So do not give IV Verapamil unless you have an idea about what you're dealing with. And we'll come to this in the next slides. So I'll tell you, to keep it short, they actually called me towards the end of this case. I got involved in the case of in the care of this patient towards the end of this list of procedures that they did over here. But I know they did vagal maneuvers and those failed, okay? So the tachycardia continued. Adenosine did not terminate the tachycardia, and unfortunately I don't have the strips.
I want to mention one thing, just in vagal maneuver, especially in SVTs, whenever you have an elderly patient, you want to do like a carotid massage, I want to emphasize the very important to listen to the carotid for Bruit.
Sure.
To avoid causing stroke, especially in the elderly.
I believe we talked about this also a couple of weeks ago, but it's important to not to leave your patient with a stroke if he comes with an SVT. So unfortunately, we don't have the strip over here. It would have been really nice for us electrophysiologists to look at it. But when we gave adenosine to this patient, we actually saw that the tachycardia continued, but we saw that some of those retrograde notches were truly P waves because they started disappearing in an intermittent way. So what am I saying here? I'm saying that we did not have AV dissociation from the get-go, but when we gave adenosine, we had AV dissociation with more V's, meaning QRS, than P waves, without really affecting the tachycardia. It did not terminate. And then if you go back to your algorithm of Brugada, when you have more V's than A's, then it's clear that this is ventricular tachycardia. So I believe, despite the fact that adenosine did not terminate it, it actually was diagnostic of ventricular tachycardia. And that's the reason why it's always important to print those strips when you're giving adenosine. Now it gets more interesting. Because adenosine didn't help, this patient received IV amiodarone, and then it also didn't help. And then when none of this helped and frustration was building up, he got the first cardioversion. And interestingly, with an electrical cardioversion, nothing happened, okay? So if you guys remember when you have your strips of electrical cardioversion, you see saturation of the signal for a few seconds just after you deliver the shock. For this guy, we don't really know what happens during the saturation, but whenever the rhythm resumes, he was still in the same exact rhythm. And he didn't have it only once, he had it actually 3 times. So it was repeated multiple times, and the tachycardia never terminated. With this, the patient got more anxious, and then after shocks, IV amiodarone, he got lightheaded, his blood pressure was 75. And this is when the electrophysiologist was asked to come and help. A little bit late, but so this is
the importance of these webinars, to be honest with you.
Exactly.
You know, not to know how to treat patients first, not to harm patients.
Sure. I have to say that, in my opinion, in this list of 5 items that you have over here, nothing was done wrong. Okay, so maybe we could have done things differently, but if you look at the algorithm that I showed you before for the acute management, none of this is really wrong because they went with the order, that vagal maneuver, gave adenosine, did not give IV Verapamil, they gave IV amiodarone, and then they did the electrical cardioversion. But obviously, it's important, we have to teach the guidelines, but we have to know that not all patients follow textbooks, and sometimes we have to think outside the box. So this takes us to the next step, and that's the reason why I'm presenting this case, okay, to kind of raise awareness about one condition that we have to start recognizing. The next step was this magic pill over here, or magic solution. So this patient, when I got there, we decided to give this patient Verapamil, okay? Now, why did I give Verapamil? I just said it's a class 3 contraindication to give Verapamil. Well, because somebody who has a narrowish or widish, whatever you want to call it, intermediate QRS, right bundle, superior axis. It looks very much like a combination of a right bundle and the left anterior fascicular block in a young patient who supposedly should have a normal heart. This should lead us to consider one entity that we call fascicular ventricular tachycardia. And then If you just remember all the names of this fascicular ventricular tachycardia, you will know all about it. It has multiple names, but each name will teach you something about it. So we call it either fascicular ventricular tachycardia, or we call it idiopathic left ventricular tachycardia. Idiopathic because it happens on a normal heart, or we call it Bell-Hassan tachycardia. Even Bell-Hassan can teach us stuff because it's from around us, and that means that it's epidemiologically we tend to see it more in Lebanon. I don't know about you guys. I spent 10 years in the US. I don't remember seeing a fascicular VT. I spent 4 years in Lebanon. I have seen 5 so far. So we tend to see it more in our area. That's why it's important to remember this type of entity. And the last name of it is Verapamil sensitive or Verapamil responsive ventricular tachycardia. And I'm cheating here. This is not the exact EKG of this patient. So for the EPs amongst us, they might notice that the morphology does differ a little bit, but that's something I don't have the tracing of that patient on this specific day. But I can tell you that with 10 milligram of verapamil, it took 4 or 5 seconds, and then like magic, he went back into sinus rhythm, did not have a single PVC or skip beat anymore. I remind you, after 3 shocks, a bunch of amiodarone, and being hypotensive and hemodynamically unstable towards the end.
Truly, it's like magic. I'm sorry.
Yeah. And Mario, just want to add something for the audience, for the cardiologists. Looking at the EKG, especially the first one, lead 2 is negative. So it's also the subtype, the posterior fascicular type. So we have several types of fascicular.
Excellent.
We have the anterior fascicular, the septal, and the posterior. It's the posterior fascicular.
Perfect.
That's the one that is most common.
Exactly.
We call
Exactly.
it Bell-Hassan.
Yeah. So the purpose of this talk, I decided, I mean, it's already a rare entity, and I'm not going to talk to you about the rare variant of this rare entity. I would rather just focus on the most common manifestation of it. So as we said, this is fascicular, idiopathic, Bell-Hassan, Verapamil responsive VT. All of those are synonyms. What is this VT, and why does it look like this? So it's important to know. This is not too much details. I believe general cardiologists should know this. This is a ventricular tachycardia that involves a conduction system. So it comes from the fascicles that are in the left ventricle. And as you know, we have 2 fascicles in the left ventricle. We have a posterior fascicle, we have an anterior fascicle. The posterior fascicle is responsible for more than 80% of those fascicular ventricular tachycardias. And if you look at the schematic that they have for you over here, we don't exactly know what's the substrate for this tachycardia, but what we know is that normal conduction goes down the posterior fascicle, and in an area just surrounding this posterior fascicle, there's an area of slow conduction. Slow conduction meaning depolarization happens slowly during electrical systole, and we have late activation of this area. And as you might know from medical school, whenever you have late activation next to normal activation, this is a perfect substrate for a mechanism that we call re-entry, and re-entry can lead to tachycardia. I know there are multiple variants, multiple explanations. Sometimes it's not all re-entry, but in general, fascicular VT comes from the posterior fascicle. It involves a re-entry that involves this posterior fascicle as well. Now, how do we remember how it looks? It comes from the posterior fascicle, so it looks exactly like somebody who has normal conduction going down the posterior fascicle and blocking in the anterior fascicle. It's not the case, but it looks like somebody who has a left anterior fascicular block. And activation starts in the left ventricle. That's why it gives us a right bundle morphology with a left anterior fascicular block kind of pattern. And typically it would give us a right bundle superior axis. So that's what we call fascicular VT. Now, why do we call it verapamil sensitive? Because we know that verapamil, it terminates those arrhythmias, and then how does it terminate them? It has a direct effect on this slow conduction zone that I'm showing you with the mouse, if you can see my mouse. So when the slow conduction zone is further affected by verapamil, the tachycardia would immediately stop. We have nice tools to kind of characterize the substrate for this tachycardia that we electrophysiologists choose. I'm not going to bore you with all of those. But for you, remember, it's not here, but so this is a VT that happens in patients who have normal hearts. It's actually 10% of the VTs that happen with normal hearts. So the majority of VTs are what we talked about last week, outflow tract ventricular tachycardias or PVCs. This left ventricular idiopathic VT is only 10% of those VTs, but it has lots of variation, as I said. So in our area over here, we tend to see it much more than Europe and the States. And I know in the Asian population, it tends also to be really common, and that's why most of the publications are from Asia and Japan about this fascicular ventricular tachycardia. Typically, it happens in people, it starts manifesting when somebody is between age 20 and 40. It's usually not related to exercise. It happens more at rest, unlike the other outflow tract tachycardia. And then it doesn't really cause sudden death. So people do not die from fascicular VT, but it can be really fast, it can be really symptomatic, and it can lead to pre-syncope. Okay? Oops. So how do we treat this? So this is the guidelines from the Al-Khatib guidelines from 2017, the recommendations. And in patients with verapamil sensitive idiopathic left ventricular tachycardia, okay, so the treatment, the first line of treatment is catheter ablation. Instead of keeping somebody on a pill for the rest of their lives, we can actually ablate those tachycardias and inhibit any recurrence with 90% success rate. If the patient is not interested in catheter ablation, then we can use alternatives, which are medication, and verapamil is actually the most effective. Beta blockers can also be effective, but we typically use verapamil for those tachycardias. We use it for two reasons. One of them is to terminate acutely the tachycardia, and the second one is to prevent recurrences. Now, I'm going to ask you to allow me to show those two slides before I stop, and those are for my friend's EP. So this patient that I presented to you, he left the ER in normal sinus rhythm, decided to keep taking verapamil, follows with a colleague of mine, and preferred not to have his ablation procedure, and has not had any recurrences, is doing very well. That's another patient that I'm showing you over here, who actually had recurrent fascicular VT, and despite being on multiple antiarrhythmic, including beta blocker, verapamil, and then antiarrhythmics, and then he kept having fascicular VT. It was really horrible for him. He kept having 3 to 4 hours of VT every single day. He was 44 at the time he presented to me. And this is why I'm showing you this beauty over here for us electrophysiologists. That's a VT. And look at the first 3 beats of this VT. The first 3 beats look very much like sinus rhythm. And then it becomes wide, okay? And why is this the case? I mean, that's a rare manifestation of a rare disease, but sometimes those fascicular VTs that involve the fascicles, the route of re-entry can exit very close to the high septum, and we call this upper septal fascicular VT. If it does this, it starts activating the heart the same way the sinus rhythm activates the heart, down both fascicles. And that's why within the same rhythm, you see VT that's wide, and that looks very much like the fascicular VTs that I showed you before, but you also see beats that are actually very narrow, and this is typical of what we call upper septal ventricular tachycardia. So we took this patient to the lab, and then we proved that we have an area of slow conduction, and then we mapped to look at this Purkinje potential that we call Purkinje potentials, meaning the posterior fascicle. And then finally, what you have here in what you call this color mauve in purple is the His and then the Purkinje potentials. And then what you have in blue over here, the blue dots, are areas of slow conduction. And then the pink dots over here and the red dots are areas of ablation. That's not where the typical posterior fascicular VT would be. This is higher up in the septum. And for this particular patient, this is where the successful ablation was. And he never had VT after this. With this, I'll stop. I'll take any questions if we have time, with much hope for better days for Lebanon.
This is a great case, Mario. One thing I want to emphasize, especially for general cardiologists, when they see this this pattern, it's important not to basically refer it for ICD.
Excellent.
Especially that in Lebanon, sometimes ICDs are being implanted by non-electrophysiologists. So it's very important because they'll be doing a disservice for the patient if they get an ICD.
Excellent. And that's the best example. We talked about this last week. We kind of talked about this, but this example is the best reason why you should not give an ICD, because I remind you, this patient got 3 shocks, and they did not put him back in sinus rhythm, because this VT is driven by adrenaline affecting his conduction system. With every shock, he's going to have more adrenaline, and you're going to have more VT. And then if he had an ICD, he would have emptied his ICD with what we call VT storm, and it would have been really horrible for this patient. who otherwise was stable with his VT.
So a question from the audience here. This case could have been missed and diagnosed as SVT, totally agree, after unsuccessful vagal maneuver and adenosine, yet gets terminated with verapamil. So we do see sometimes these cases in the ER, SVTs with aberrancies. Cannot tell if there is AV dissociation or not, because most of the time to be able to diagnose it, or what gives out the diagnosis in these cases truly is not the typical Brugada criteria, is more than when you see the AV dissociation. But so if you try a vagal maneuver, doesn't work, adenosine doesn't work, then when you give verapamil, now it works, it can still be an SVT in your mind.
I completely agree, and then that's an excellent question. The last case that I showed you that had an ablation done was referred to me by a colleague who did a slow pathway ablation for AV and RT on the patient. And then while doing the slow pathway ablation, he saw that the patient had AV dissociation during tachycardia.
Yeah, interesting.
And then felt, okay, you know, I'm doing a slow pathway ablation, but he knew that that's not enough for the patient. That's not what he should be doing. Then he said, let's send him for VT ablation, and that's how the patient ended up being referred to me. It's a rare, more or less rare case. We see AV and RTs every week, several cases. We see this really rarely. So that's probably why we don't get them confused this much, because they change. I mean, the epidemiology makes it as such. And then not everybody will have one-to-one conduction in fascicular VT. But the key is to see that you have AV dissociation. And then keep in mind, whenever you have this right bundle with the left anterior fascicle pattern, that's very typical of fascicular VT. If you have a functional right bundle, usually with AV and RT, and oftentimes with elderly people, it would not have a left anterior fascicular pattern as well. It can, but it would not be the typical manifestation. Unless somebody in sinus rhythm had also right bundle and left anterior fascicular block, then you'd expect to have the same in SVT, if this is AV and RT.
Right.
So what I'm saying, to keep it simple, if you have a new narrow right bundle with a new left axis deviation that looks like left anterior fascicular, it should direct you towards fascicular VT much more than SVT with aberrancy.
Exactly. So when we have right bundle superior axis and it only responded to verapamil, yes, it can still be SVT, but it should at least make you think that what I'm dealing with, it's a verapamil sensitive VT.
Exactly.
Great. So the next question is, would you have given verapamil as first line if you found an ECG as typical as this one on admission?
I honestly would. Because when they called me, I got, so I don't know how you guys practice, but we practice WhatsApp medicine. So I was walking, look at my phone, and I said, give verapamil. They said, oh, we already did 3 shocks. I said, okay, stop, give verapamil. I would have done it because that's a pattern I recognize. But I wouldn't blame people for not recognizing the pattern. It's not a common presentation, not a common disease. But I believe all of us, the 3 of us here, would have probably done the same.
Totally.
Because the pattern is very suggestive of a
So now most of the audience can be able
Right,
to diagnose these and give verapamil for.
Sure, but please do
cases.
not give somebody who has a right bundle and left axis deviation and who starts having a VT that looks funny and he has a bad heart and he has hypotension. I mean, I'm trying to be here subtle because remember, it's a class 3 indication to give verapamil for somebody who has cardiomyopathy. Yeah. So let me put it this way. If you believe that this patient might have structural heart disease, do not give verapamil, okay? Do not give verapamil. If you believe that this is a patient who has a normal heart, okay, young patient, normal heart, normal EKG when he was in sinus rhythm, then definitely feel free to give verapamil when you have such a pattern.
Now, sometimes for the patients with fascicular PVCs, that can cause cardiomyopathy. You have those patients, we've seen those cases with those patients, we've given them verapamil just to suppress the PVC, and we've kind of swallowed the risk of heart failure on verapamil, but because knowing that suppressing the PVC will improve the LV function. So these are particular cases that one should think clearly about and
probably
be careful about.
A good message also to the audience, whether cardiologist, emergency doctor, when you have an EKG like this, get your phone, take a picture, send it to your closest electrophysiologist. Okay, there's no harm. That's what we do for a living. So when you have EKGs like this, consult cardiology. I believe that's the way to go.
The other question is, should we start with verapamil 10 or 5?
I gave 10. I believe I gave 10 for this patient.
I don't believe in 5. I almost always give 10. Great. Okay. Great.
take a break. And
So we're gonna break for 2 minutes, then we'll proceed with Dr. Refaat.
So we will resume with our second case with Dr. Marwan Refaat, who's going to also be talking about a very interesting topic to all of you guys. And we will try to make it shorter from now on because I exceeded my allowed time.
thank you very much, Mario, for the introduction. Thank you, Bernard, for the invitation. I'm going to talk about a case that's common in our area, in the Mediterranean area. So hopefully it will be helpful to general cardiologists. I have nothing to disclose regarding this presentation. I'm going to talk about a condition called arrhythmogenic cardiomyopathy. This condition traditionally have been called arrhythmogenic right ventricular dysplasia, or ARVC. What is this condition? This condition is due to a fibrofatty replacement of the myocardium. So in the RV, initially when it was described, the myocardium got replaced by collagen and fat, and that's why it was called ARVC or RVD. However, with time, we noticed that this condition not only is limited to the right ventricle, however, it can happen in the left ventricle. So now the common terminology is called arrhythmogenic cardiomyopathy. And typically, patients can present to the general cardiologist or to the internist, and of course to the electrophysiologist, with episodes of pre-syncope, syncope, and it's one of the conditions that can predispose to cardiac death. Many of the cases have traditionally been reported from Italy. However, we knew now that it's not just Italy, but it's common also in our area, in Lebanon and the Mediterranean area as well. And sometimes we need to look for it to see it. I mean, if you limit the diagnosis and do further testing, you might miss this condition. So it's very important to be comprehensive when you suspect this condition. It's a familial disorder in 30% of the cases. It's autosomal dominant, and many chromosomes have been, and genetic defect mutation have been involved in this condition. It happens with variable penetrance, and it accounts for around 2% per year as incidence of cardiac death. And this is basically a slide from a patient with arrhythmogenic cardiomyopathy, and you see basically the collagen and the fat replacing the myocardium, and here you see basically how the RV is dilated, and basically you see some fat replacement on imaging, MRI. Initially, it was reported several decades ago by Dr. Frank Marcus and also Dr. Guy Fontaine in Circulation 82, and I had the pleasure of meeting Dr. Guy Fontaine a few years ago. So what do you see on EKG? Basically on EKG, what you're going to see, and very important for the general cardiologist to notice this, you're going to see some repolarization abnormality. Typically, you see T-wave inversion in the right precordial lead, V1, V2, V3, and sometimes it can go up to V4. We talk a lot about an epsilon wave, a problem in depolarization. You see an extra notch in V1. It's usually specific, but not sensitive. If you see it, basically, you highly should suspect this condition, arrhythmogenic cardiomyopathy. And the QRS usually in V1 is more than 110 millisecond. Basically, as I've mentioned on the EKG, you see the repolarization abnormality. This is the most common abnormality you're going to see, and you can see also some incomplete right bundle, and on occasion you can see some right bundle branch block morphology on EKG.
So if I may stop you here for a bit, Marwan, this is a very important point about the EKG, because a lot of those cases go undiagnosed.
Absolutely.
So one should be looking carefully about ARVC in someone, in any lady with T-wave inversion up to up to V4.
Absolutely. If you see T-wave inversion till V4, don't take it as normal. You have to basically do further testing.
So even if the echo is normal, go beyond an echo?
Absolutely.
All right.
Absolutely. And I want to emphasize this because on echo you might miss it. On echo sometimes, in this case I put it, it's typical, and you saw it on echo. On echo you see clearly that is on RV dilatation, and also you see the decreased systolic function of the RV, but sometimes it can be subtle and you might miss it on echo. You have to do an MRI. And on MRI, you're going to see basically the rosette enhancement. You're going to see sometimes the fat replacement, and sometimes you might see some basically changes that can give you an idea that it might be latent, and it might give you information that the patient might carry this condition. So very important to diagnose it. And this is basically the patient when we had the tachycardia, and you see here basically in ventricular tachycardia. Typically when they happen from the right ventricle, you have ARVC. They tend to have the morphology usually in V1 is negative. We call it left bundle morphology, VTA. And it's a problem. What's the problem in RVC? So if you remember back from the basically the cells are linked together by glue. There is a glue that sticks the cells together. These are called the desmosomes. Problem in those glue or those desmosomes causes problem. Basically the cells are not going to be attached very well, and then you get those degeneration and fatty replacement and collagen replacement. Okay. And the many genes have been involved, basically mutations in desmosome and non-desmosomal genes. Desmosome, the typical one and the most common one is plakophilin 2, but you can see also as a gene including desmoglin, desmoplakin, desmocolin, and non-desmosomal genes like the ARVC receptor, phospholamban, and the TGF-beta-3 and the transmembrane protein 43. Very important, and now genetic testing is available. Many centers, they offer this gene testing. I know at our center at UBMC, we offer it to patients. I know at other centers, they offer it as well to their patients. So you should be important that if you order the test, what is the yield of the test? Usually the yield is around 30 to 54%, okay? And it's very important that if you have family history with multiple sudden death, this will enrich the yield. You might get yield up to 58%. And as I've mentioned before, it's an autosomal dominant condition, and they have variable penetrance, but there are some rare recessive forms. Sometimes, actually, around 48% of the patients might have more than 2 mutations, okay? But something is very important to note, that though the most common gene mutation is plakophilin 2, in some cases you might need another hit, another mutation to manifest the signs and symptoms of the disease. And also, what's also important to note, that some healthy control population may have an incident abnormal plakophilin 2, like in Asians it's around 6%, and desmosomal mutations are also, in some data from the Finnish group, it's around 0.5%. So how do you make a diagnosis? Now we have task force criteria that takes into account many features, including structural disease, repolarization abnormality, depolarization abnormality, family history, arrhythmias, tissue characterization. We have major and minor criteria. So if you have two major, or one major, 2 minor, or 4 minor, we make diagnosis that this patient has ARVC. Now to make this interactive session, and I want to ask you a question, and I want to take the opportunity for you to answer it hopefully in the chat box. So you have Sami, who has ARVC. So you come to the cardiology clinic, to your clinic, and you know that he has this condition, ARVC, and it happens to have gene testing. It was ordered, and you know that he has plakophilin 2 mutation. So this is very important because you're going not only to treat the patient, we're going to treat the family. This is very important. So a patient comes to you, you know he has ARVC and he has this mutation. This patient has 2 children and also he has a sister who all happen to have the same mutation. What do you advise? So I'm going to give you 5 options, and hopefully you can answer this before going into answering this case together. So 1, his 7-year-old son should undergo an ECG, echo, and MRI, cardiac MRI. B, his 15-year-old son has normal ECG, echo, and MRI, so no further testing is needed. Option C, his 60-year-old sister has a normal ECG, echo, and MRI, cardiac MRI. Screening should continue every 2 years. Tell her to come back in 2 years. Option D, since all of this family, they have mutation-positive disease, and the plakophilin 2, we know it causes ARVC, we should implant ICDs in all of them. And option E, a mutation-positive family member should be advised to limit high-intensity endurance physical activity. So what do you think is the right answer? Okay, I'm going to give you a few seconds, 30 seconds.
So that's very interesting, and this is how I'm glad we're starting to introduce more and more genetic testing into the thought process of any cardiologist.
Yeah, and this is, you're going to get it more and more. When I initially came to Lebanon like 8 years ago, this was very expensive. When you ordered a gene test, it was several thousands of dollars. Now, the good news, I mean, I have some good news, that since basically genetics have been improving and the technology has been improving and moving fast, the cost has been going down. And now you can do a gene testing for, I mean, it depends. I mean, there are some panels, sometimes you have exome sequencing, but you can, in $1,000, do a gene testing. And so this is available, and this will help not only the patient but the family as well. Okay. So
great.
We have some answers.
Not yet, but let's move on. Okay.
So we'll give you 10 more seconds. I'm going to move forward just for sake of time. Okay. So let me move forward. So let me mention about the implication of gene testing, especially to the family. So very important family screening. So ARVC is detected clinically in 35 to 40% of first-degree relatives. Okay, so brothers, sisters, parents, and offspring. 35% of mutation-positive tend to develop basically progressive disease expression. And mutation-positive asymptomatic patient, they have 8 to 16% risk to have major arrhythmic event over the next 7 to 39 years. And also very important, especially when you get like a test that's negative, because not all secondary mutations are described in a negative test may not necessarily preclude at least a single clinical screening. So very important to take the test in a grain of salt, especially as I mentioned before that the yield is around 50%. So sometimes it's very important, if the test is positive, it will help you. If it's negative, not so. However, if in the family you know that you have this mutation in the family, if it's negative, it can reassure family members.
So this is the most important point,
Exactly.
in fact. So when you determine what's the mutation, then you screen the first degree relatives.
Absolutely.
The ones that are negative, they're good.
Exactly.
But the ones that are positive need to be followed closely.
Exactly. Absolutely. Now, one thing that's very important, especially in those that have the mutation, just the mutation, okay? Gene testing by itself do not impact ICD decision. So we don't put ICDs just for the fact that we detected the mutation. This is very important to basically pinpoint this information. And it's very important to adjust the lifestyle of the patient, do some lifestyle modification. Because we know that patients who have the genotype positive, if they embark into exercise and sports, they are highly predisposed to have ventricular tachyarrhythmia and sudden cardiac death. So very important to, and I'm going to mention what they can do, but they have to limit their sport participation. Also very important, especially in those who have genotype positive, to basically monitor them, do ECG, echo, and monitor the arrhythmia, do Holter testing. Now, very important to answer the question I mentioned. This is from Dr. Fram Marcus' paper in JACC. It help us a lot. How do we basically manage the family? So basically, if we have mutation positive family member, so patient comes in, and how do you screen their family? So very important to know that cardiac evaluation begin at an age of 10 to 12 years. The disease rarely expresses before then. Okay. So in the case I mentioned, the patient had like a daughter, 6-year-old. You don't have to go and start doing cardiac MRI and ECG, echo. I know sometimes it's done, but if you follow the guidelines and the publication, usually we start 10 years and above. Now, very important that the evaluation need to be repeated every 2 years. Like if basically if a patient like at 15 years you don't find anything, you need to revisit the workup after 2 years. And one thing very important that we can stop screening at an age of 50 to 60. Like for example, his sister, who was like in the case I mentioned, was 60-year-old. Basically, you don't have to keep basically screening and doing the whole workup again. So disease really starts after this time. Okay. Now this is data from Dr. James, published in JACC a few years ago. It showed basically how exercise can basically increase the penetrance of the disease and arrhythmias in patients who have the mutations. So we see basically those who are athletes here in green, they have more events, more heart failure, like class C heart failure, more sustained VTAC, VF, compared to the non-athletes. Also, if they increase the exercise, how they have more events. So very important to limit the exercise. But how we can limit? What is the cutoff? So from the basically the publication, recent publication and guidelines, we tell patients to limit exercise intensity and duration, and I'm going to mention what does it mean. They mentioned around 12.5 MET hour per week, or if you want to go by year, 650 MET hour per year. I mentioned what do we mean by those. But very important to know that patients who have mutation-positive probands and positive family members, they have higher risk of sudden death with exertion. That's why vigorous exercise is detrimental, and the patient need to limit physical activity. Both high intensity, high duration, endurance need to be limited because they accelerate the penetrance and disease progression and the arrhythmia risk. Now this is a cartoon. This is published from Heart Rhythm from last November, basically last November 2019. There was a task force from arrhythmogenic cardiomyopathy, and here, for example, patient need, of course, you should not let them do the sports that have high METs, like cycling, like ski racing, even like rowing. So basically, we tell them to do like basically sports that have low METs, like for example golf, basically some sailing, like. Maybe they will not give the full.
That's not called sports.
We can debate about it, but yeah, we have for their own sake, they have to avoid high intensity.
But Marwan, so one important point, because we have patients who say, okay, I'm gonna exercise and take the risk. I have an ICD. It's gonna save me if I have a VT. But you mentioned this, if you could stress this a little bit more, it's not just for the arrhythmic risk, it's also for myocardial function, and they can develop progression of heart failure.
Absolutely. So it's very important to limit it. So back to our case that we discussed, basically the answer should be that mutation-positive family members should be advised to limit high-intensity endurance physical activity, okay? So the other answers, I answered them, are not correct.
Right.
Okay? I'm going to end basically this presentation of this case that I thought of importance to point to you, because this disease is common in the Mediterranean basin, and you might face it, you might see it in your clinic. So it's very important basically to know how to manage it and also to manage the family as well. Lastly, I'm going to refer again to the paper that my colleague mentioned, published by Dr. Hassan Al-Khatib. Basically, it's a landmark paper that I'll advise all of you to have a look at it. It was published. It tells us how to manage patients with ventricular tachyarrhythmia, and also it mentioned about special population, including this condition. So basically, this condition, sometimes we need to implant ICDs. So for example, SAMI would need to have an ICD in which condition? It's a class 1 indication for a patient for ARVC to have an ICD implanted if they are resuscitated from cardiac arrest or if they had sustained VTAC. Very important. Also, patients who have significant ventricular dysfunction with RVEF or LVEF less than 35%, they need to have an ICD. It's a class 2A indication to implant ICDs in, for example, in our case, like Sami's case, in case he had syncope presumed to be due to ventricular tachycardia. Very importantly, it's a class 1 indication that patients who have ventricular arrhythmia and ARVC and arrhythmogenic cardiomyopathy need to be on beta blocker. And also, it's a 2B indication is to risk stratify patients with ARVC with an EP test. Basically, put a catheter and try to see if we can induce tachycardia. An important armamentarium in the management of patients with ARVC is catheter ablation. So a catheter ablation, basically it's a 2A indication to do it for patients who have recurrent symptomatic VTAC in whom beta blocker is ineffective or not tolerated. And I want to emphasize it's very important because initially, when there was the group at Johns Hopkins who have large expertise in treating patients with RVC, they published their data about ablation. They mentioned ablation, basically the patient tend to have more recurrence and maybe not very effective. However, many other centers, including the center at Pennsylvania, UPenn, Dr. Mashinsky's group, and other group have shown that catheter ablation is very helpful in those patients because, especially that you don't need to focus only on the endocardium because many of those patients will need also an epicardial ablation. But it will be helpful to control their arrhythmia, especially if you're not controlling it with medical therapy alone. Now I'm going to end with few tips for you as well. I'm re-emphasizing that gene testing findings do not impact ICD decision by themselves, but they can help. Basically, first of all, it cascades screening of the family, and they can help those who don't need to be frequent testing. And also, I'm going to just something that, of course, these diseases have to have more arrhythmia as well. ARVC patients, because they have sometimes some scarring in the atrium. You can see some AFib, some atrial arrhythmia, and the group at UCSF, Dr. Scheinman's group, I published a high incidence of atrial arrhythmia in patients with ARVC recently. But one thing I want to mention, if beta blocker fail, okay, there are other antiarrhythmics that we can give to patients with ARVC, including flecainide. And also recently, the group, also at UCSF, Dr. Mel Scheinman, who was also my mentor, published basically a few years ago, 2017, a combination. If flecainide is not helpful, we can flecainide with combination of sotalol can also be effective in some patients controlling the arrhythmia. However, I want to advise you all, if you see such patients, to refer them to specialized care, ectophysiology. We might need to help them by doing, of course, ICD ablation. I'll take the opportunity to thank you again for listening to my presentation. Thank Dr. Bernard Abi Saleh for the invitation. Happy to take any questions.
Great, Marwan. This was a great discussion about ARVC that is prevalent in our country. There is a question from the audience here. If you have a patient with RVOT-VT, normal echo, EKG is normal except for the PVCs or the VTs, do you need to do an MRI on these patients?
So there are some PVCs, and Dr. Kurt Hofmeyer published a paper a few years ago how to distinguish. There are some PVCs, I mean, though they're coming from the RVOT, but they can be more prevalent in ARVC if they are wide, if they are notched, so they can give us some clue. Okay, and there's a score as well. He put a nice scoring system, Dr. Kurt Hofmeyer, a scoring system that, and if the patient had high score, it tells us that this EKG, this PVC, though it looks like from the morphology on EKG, it comes from the RVOT. It could be suggestive of focus due to ARVC. And I tend in my clinic, when I see patient with RVOT, I tend to do MRI just to make sure there is no structural heart disease, there is no ARVC involved as well. But usually, if you see more than one morphology of PVC, if you see wide PVC, if you see notching in the PVCs, these are all like clues for you that you might be dealing with ARVC.
The way I personally approach this, I ask the echocardiographer to take very good images of the RV, just to make sure that the echo is reliable, and not end up doing MRI on all of those patients. Now, it all depends on the level of the suspicion.
I will do it, especially if the QRS is wide, especially in lead 1. if I see some notching, if the PVC is notched, I don't have example, but if you see some notched QRS, and if you see on, sometimes I do Holter on those patients, if you see like multiple morphologies, not just, I mean, you can sometimes see a dominant morphology, but you can see other morphologies as well. It can give you a hint that maybe you are dealing with a sick RV.
Yeah. I happen to do echo and EP, and I can say echo is not a great tool for the RV. I mean, that's my humble opinion. We can see stuff, but MRI is always good. Now, unfortunately, now we're tending to see also stuff being overcalled by MRI, and there's a nice article about all the artifacts that can mimic ARVC, including tethering of the free wall and all of this. So it's rare to see an MRI that's completely normal. Not every single anomaly on MRI means the patient has ARVC, so you have to be careful and then look at all the aspects of the diagnostic criteria.
Great. And this is a great point, my dear friend Mario, and it also, for the general cardiologist, it points that it's very important when you want to do it or refer your patients to do have an MRI, you have to refer them to a center that has a good expertise in reading those MRI, basically to help in the management of your patients.
Totally. So, but also, I'm not an imaging guy, but you know, when the patient is in by Germany, for example, or Germany, it's so hard to gate those images for the MRI, so you end up with all kinds of...
So now what we can do when we ablate them, I don't know if you guys do this, but we also can do voltage mapping in the RVOT, and then we tend to do an EP study when we're suspecting that things might not be completely idiopathic.
Absolutely. And in the voltage mapping, just for the EP, very important to do both bipolar and unipolar, because sometimes you can do the bipolar voltage mapping, it will be totally normal. However, if you do the unipolar voltage mapping, it will be abnormal because the unipolar give us more information of the epicardium.
But for the general cardiologist, another point that we talk about, and I would like to re-emphasize this point about the negative T wave. So if ladies with negative T wave in V4 or man in V3, look for ARVD, maybe not only by echo.
Absolutely.
Okay. Unless young guys, so people who are less juvenile T waves can be a normal variant. So
in the US, especially in blacks,
African American as well.
African American that you see it, but but you have to be cautious, especially that, as I mentioned before, it's not just in Italy, but it's more like Mediterranean basin. So
it's prevalent
we see it in our area.
Great. Thanks, Marwan.
Thank you very much for the presentation.
Thank you, Marwan. So we're going to move to the next talk by our chair of the work group and the webinar, Dr. Abi Saleh.
Thank you, co-chair of the working group.
Tini لردلك.
Always nice. So, Dr. Refaat and Dr. Njeim presented very interesting cases, very important to recognize, and I'm sure you guys learned a lot from these cases. But these were rare scenarios, fortunately, because we don't want to see ARVC every day. We don't want to be a diseased population here in Lebanon. I chose to present something very common that one would see maybe at least weekly or in the ER, I'd say weekly or twice a month. This is a case of someone who came in complete heart block. All right, so it's someone who's 73-year-old. Came in, loss of consciousness, he's on a beta blocker, he's on an ACE inhibitor, and he's now only responsive to painful stimuli. So comes in obtunded, maybe in ambulance, his blood pressure is 50 over palpable, his heart rate is 25, things are not looking good. So the ECG, as this rhythm shows, he's in complete heart block, AV dissociation, you see the P and the QRS is totally unrelated. Maybe some of you would say, well, this I'm seeing PR prolongation. No, it's not PR prolongation. If you have in a regular ventricular rhythm, this is an escape. This is not a QRS that is caused by the P wave. So this is totally a AV dissociation. So the patient is not doing well. He's critical. So what should you do? Should you start transvenous pacing? Should you put a line and do transcutaneous? Should you put a line, do transvenous pacing? Should you do transcutaneous pacing? Should you give glucagon as an antidote to beta blocker? A lot of people forget that glucagon is an antidote for beta blockers and calcium channel blocker. Now, it's not the best antidote, but it's worth trying. D is urgent heart cath, and E is atropine. Well, in my mind, you can do several of these options. I would right away start transcutaneous pacing. because this is the fastest thing to do. And I would give glucagon. Glucagon, if it's going to work, it's going to take an hour or two to kick in. But in cases like that, you don't have time to put in IV line to pace the patient. Obviously, no urgent cat whatsoever. Atropine would not do anything for these patients because this is not a sinus bradycardia. This is complete heart block. Atropine would not do anything. In fact, it might even make things worse. So don't give atropine for such case.